Good day, students. Without much ado, we shall directly plunge into today's topic. Rats racing against time for students in pathology. A case history. A 55-year-old cachectic male was brought to the hospital with complaints of a ball rolling movement in his epigastrium. In addition, he gave a history of blood mixed vomitus on and off. The doctor referred him to a gastroenterologist and an endoscopic examination was done. Subsequently, a biopsy was performed. I hope you people can make a diagnosis. What is the diagnosis? Discuss the etiopathogenesis, gross and microscopy of the disease. Add a note on the fate, diagnostic aids, and differential diagnosis. And this is how we are supposed to present our answer. Good. The answer is gastric cancer. The word cancer is just mentioned because we do not know what histological type of malignancy it would be. And the plethora of importance is shown in this enclosure. Think of the subheadings. The subheadings will take you to the answer. The topic appears very simple, but then we should break it up into all these subheadings and subsequently try to cover each one of them. The causes. It can be dietary, genetic. Dietary, mostly because of smoked fish, supposed to be common in Finland, etc. And it contains benzopyrene. Food with some kind of preservatives. Salted food with nitrates and talc rice, more common in Japan, along with asbestos, can lead to a malignancy. It is considered to be more common in blood group A and associated with smoking. Coming to the gastric causes, it can be preceded by a chronic atrophic gastritis, H. pylori induced gastritis, with or without intestinal metaplasia, a pernicious anemia. It is an autoimmune disorder, but then it can coexist with this malignancy. And any history of previous gastric surgery we should have in mind because it can subsequently present with a malignancy. So these are the list, and you people should by heart this list because it is part of an essay. And that again is well explained in this flow chart. There is a normal gastric mucosa which can be infected with H. pylori, or there can be a dietary factor such as a low vitamin or a high salt diet. All this can lead to a chronic superficial gastritis, followed by an atrophic gastritis, resulting in intestinal metaplasia. What do I mean by this word intestinal metaplasia? Part of the gastric mucosa or the glands are being replaced by an intestinal type of epithelium. And this can later on lead to dysplasia and malignancy. This flow diagram is very important because it gives you a flow of ideas. Normal, superficial gastritis, atrophic gastritis, intestinal metaplasia, dysplasia, and cancer. So this will be the sequence of events. Please put it in one corner of your answer page. Coming to the classification. Classification is an aid to orderly thinking. And we shall concentrate on the major malignancies, adenocarcinoma, most common. And this itself is subdivided into the following histological patterns: papillary adenocarcinoma, tubular adenocarcinoma, mucinous adenocarcinoma, and signet ring cell carcinoma. Then there is one called as adenosquamous. It contains both the components, adeno and squamous. Rarely we can have a pure squamous cell carcinoma in the stomach. Small cell carcinoma is very rare, and sometimes we get what is called as undifferentiated. We are not able to qualify it further. So it is called undifferentiated. So this will be the list of gastric malignancies. Please make a note of it. And this we people should remember. There is a classification called as Lawrence classification and now called as Lawrence-Diot classification. Under this, there are two major types. One is called a gastric type of carcinoma, which is diffuse. And there is a description for it called as Linitis plastica, which we shall be seeing. Another type is intestinal or localized. So there is a gastric type of carcinoma and an intestinal type of carcinoma. This is what I meant. In one, I find that there is an ulceroproliferative lesion. When either you put up an endoscope or you open up the abdomen, you find that there is an ulceroproliferative cauliflower-like growth that is staring at us. In another, the endoscope will not be able to find anything, but there is a uniform, diffuse thickening of the gastric wall. So this is called as the infiltrative type. This is called as ulceroproliferative. In ulceroproliferative, there can be very bizarre and diffuse glands as is shown in the picture. Whereas in an infiltrative, we get what is called as signet ring cells. This again I shall be explaining in detail. For the time being, remember the two types, ulceroproliferative and infiltrative. This again, I hope you people will be able to describe it. It can be kept as a specimen for you. We need not get bewildered. Why do I say it is a stomach? Because it is a huge sac-like specimen. There are only one or two sacs. One is the urinary bladder, other is the stomach. And in this, I am finding a large ulceroproliferative. Why I am saying ulcer? Look at this mucosa. Suddenly, there is a loss of the mucosa. Therefore, it is an ulcer. Secondly, it is protruding and it is friable. We call it as a cauliflower-like growth or an ulceroproliferative growth. And these are the gross patterns that we should mention. Proliferative, ulcerative, a combination of both, which is called as ulceroproliferative, and infiltrative, which we shall be seeing. The tumor measures several centimeters, grayish white in color, and it is surrounded by the normal mucosa. So I hope you people will be able to make a diagnosis if you get this specimen. It belongs to ulceroproliferative type of gastric carcinoma. And another one is infiltrating or infiltrative. So in this, I find that there is a thickening of the wall. This is called a Linitis plastica or a leather bottle like stomach. Look at this one. Normally it is a very collapsible and flimsy organ. But here the surgeon or the pathologist is having some difficulty in opening it up. And there is a uniform thickening of the wall. When I look at the mucosa, there is no lesion that I can see. This is one type. And ulcerative is another one. We had earlier seen it in the differences between a peptic ulcer and a gastric ulcer, carcinoma. So in this, I find that there is a large ulcer. Look at the blackish necrotic debris, and the edges are slightly everted and undermined. So this again is a leather bottle stomach. What is this leather bottle stomach? This is a picture of it. This is a kind of a water bottle that usually the people in the desert, etc., in the old cowboy movies will be carrying. And it is a plain water bottle, and see that there is a lot of similarity between the two, and hence it is described as a Linitis plastica or a leather bottle stomach. This is classical of an infiltrating type of adenocarcinoma, but it can be seen in some other conditions such as syphilis and lymphoma. Early gastric cancer. One of the countries where adenocarcinoma was common was Japan. But then Japan is also technically advanced. They developed all the endoscopes, and because of that, they were able to make an early diagnosis. Now, what happens in an early gastric cancer? There is, you are able to see those dark areas. All the dark blue indicate that there is a lot of nuclear proliferation, crowding of the glands, and they are bizarre. But it is not crossing the mucosa, it is not invading. Therefore, it is limited to the mucosa. And look at this picture over here. This is a mucosa, submucosa, muscularis layer. In one, I find that there is a protruding or a nodular type of lesion. In another one, it is superficial, mildly elevated. In the third one, I find it is almost in plane with the surrounding surface, flat. And later on, it can be depressed. And in the last type, there can be an excavating. Remember the word cave. So it is slightly depressed and it forms a cave-like structure. So these are the types: protruded, flat or slightly elevated, depressed, excavated. These are the variants of the early gastric cancer. Because of this, they were able to make an early diagnosis and the prognosis in the patient is excellent. One type is an adenocarcinoma with the signet ring cells. I do not know whether you people can see, but if you observe carefully, this dot is the nucleus and this entire thing is the cytoplasm. The nucleus is being pushed to one side, and we can confirm our diagnosis by doing a special stain. These are the special stains, the periodic acid shift or the magenta. Halcyon blue, it produces a blue color, and music carmine, it produces a red color. Please mention these stains, you score a mark. If you cannot understand, see this picture. Now it is not clear, but in these cases, the cytoplasm has taken a magenta color with the PAS stain. And by the by, what is the signet ring? It is the ring of a king. So there is an emblem that is here. Those days the kings will not be signing the papers. There, this emblem will be endorsed onto any document. And that is the meaning of it. And this exactly has got the shape of these cells. Or rather, the cells have got the shape of this ring. It is called the signet ring appearance. Again, a signet ring here, picture from the British Museum fingerprint. And here you find that there is a fingerprint like thing. This can be endorsed onto a document. I think this picture is clearer than the earlier one, a higher magnification from web pathology. I find that the nucleus is pushed to one side and there is a cytoplasm having a slightly bluish or almost empty looking appearance. And it is infiltrating the tissue. Signet ring type of adenocarcinoma. And what are the methods of making a diagnosis in a gastric carcinoma? Endoscopy, first and foremost. The gastroenterologist will be putting in a tube and he'll be able to make a diagnosis. Biopsy, mandatory, the ultimate gold standard. Laparoscopy, sometimes they put in an instrument and then find that there is a huge lesion. Ascitic fluid, the patient will be having ascites, and when you tap that fluid, it can be having malignant cells. Without invasion, an ultrasound can make us suspicious of the lesion. And if at all the patient is having a metastasis, FNAC from the liver or a liver biopsy, and then an FNAC from a lymph node, supraclavicular lymph node classically involved in gastric tumors. All these are a panel of diagnostic aids which should not be missed. And the tumor markers are as given here: CA 72.4, CA 19.9, and CEA, carcinoembryonic antigen. This you people would have seen elsewhere also, and this can be positive for a number of tumors and not very specific of a gastric adenocarcinoma. What are the modes of spread of the gastric cancer? One is a direct spread. As we mentioned earlier, it originates in the mucosa, goes into the muscularis and the serosa, and sometimes to the adjoining organs, such as the pancreas, colon, and the liver. This is a direct spread. Blood-borne. It can be spread by blood to the liver and the other organs such as the lung and the bone. Again, I always repeat, liver and lung are commonly involved in hematogenous spread because they have got a dual circulation. And it is uncommon in the absence of a nodal disease. So there has to be a disease and then only it will be positive. The spread of a gastric carcinoma, this is a summary, this you people should write. So there is a horizontal spread, which we had seen. Vertical spread means almost like droplings. They fall, they cover the ascitic fluid, the peritoneal membrane, and even the ovary as a Krukenberg's tumor. Lymphatic spread to the various immediate group as well as the distant group of lymph nodes. Hematogenous we had seen. Transperitoneal is one. This is one mode of spread which you people must write in the spread of malignancy. Krukenberg's tumor is a bilateral ovarian tumor which has got metastasis from mucin secreting adenocarcinoma. This itself can be a question and we have covered it in the gynec pathology. So lymphatic spread is over here and see, nobody will suspect that this is going to be a metastasis from a gastric carcinoma. The supraclavicular nodes are involved and it is called as Troisier sign. There can be the paraneoplastic syndromes also, and this is one called as acanthosis nigricans. There is a pigmentation of the skin, and this should make us suspect a malignancy. And acanthosis nigricans is a paraneoplastic syndrome associated with gastric carcinoma. The sites of spread we had mentioned earlier. One is Sister Joseph's nodule, and that is a nodule in the umbilicus. And bilateral ovarian is the Krukenberg's tumor. Please mention all these. Any idea what this one is? So look at this one. It is an endoscope, a superb equipment that is making us reach areas which we can't even imagine of. And this is an endoscope. It has got a camera that is attached to it. It also has got an ultrasound like thing. So you find that the frequency will be measured. They will be able to localize the lesion. Once you localize the lesion, you can either put in and take some sample of it, or you can take a biopsy. We'll be seeing it in the next one. Or otherwise, there is a camera that is attached and that can be visualized onto a monitor. That is how you get the pictures in the endoscope. This is the endoscope over here going into the stomach, and this is the tumor from which the sample is being taken. The same picture and see the uses of the endoscope. What happens is when there is a needle, there can be an aspiration and the sample is studied. Otherwise, you find that there are provisions and they can remove a superficial bit of it as a biopsy. So these are the uses of the endoscope. If possible, you people can draw any one of these diagrams. And what are all the clinical symptoms? There can be a weight loss, anorexia, then there can be acute gastric bleeding. Chronic blood loss also can be there. Sometimes it is very gradual, patient can become severely anemic and cachexic. And the ball rolling movement which you mentioned earlier, it is a very unique sign for the gastric carcinoma. This here incidentally is the Troisier sign. This fellow, he was actually suffering from a pancreatic cancer and then he was able to see some kind of distensions and then it was appearing and disappearing. He made himself a diagnosis. I am suffering from cancer. And that is called Troisier's sign. He ultimately happened to be having a pancreatic malignancy. And the mode of treatment beyond my domain, but you people can mention surgery, chemotherapy, and radiotherapy. Please mention this. So I find that there is a rigid structure, the outline is maintained, the stomach is exactly like this, the wall will be thickened, but when you look inside, there won't be any lesion projecting into the lumen. ZZ.